And let's change the background, see what happens. That's much nicer, huh? Mm. Mm.
Mm. Mm. Mm. Mm. Mm.
Okay, we start in 10 minutes approximately.
Hi, John.
Hey, Arshad, how you doing?
I'm fine.
I'm always glad to see you here
Yeah. Good
because
morning to you.
when I see you, I see questions.
Yes.
Well, I see you actively participate in other webcasts too. I see that.
Right, right. Hmm. James is talking today, na?
Yeah, James is starting in about 10 minutes.
Yeah, yeah. Okay, okay.
Okay, I'll be back.
Yeah, I'll catch you. Yeah.
Okay. James. Ooh. Good morning, James. Oh, okay.
My camera's not working here.
Hey, James, how you doing?
Hi, can you hear me?
Yeah. Yeah, your
Okay,
camera's working okay there.
No, my camera's not working here. It's strange.
Okay.
Um, I might have to reboot my computer. Just give me a
Okay,
few
yeah,
minutes,
go ahead,
okay?
go ahead, go ahead. We got
All right.
time. Ooh. Oh my God, Aminata.
Hi, John. How are you?
Oh man, you're really jumping into it.
I've actually been around. Sometimes you don't see me.
Okay, you have your camera today? Let's see. No, you don't. Okay, you don't want to be. Okay, that's fine.
Not yet.
Okay, that's
I'll
fine.
see. Maybe I wasn't fully signed in. Let's see what happened.
Okay. Yeah, you can reboot and come back into Gmail or whatever.
Okay.
Nope, not yet. Your camera's not on. You haven't turned it on probably.
Sure. Give me a minute.
Yeah, you're getting it. You're getting it. Oh, backyard, welcome. Okay, yeah, you don't have to come in the panel. You can still interact by texting in the chat if you have any questions relating to the webinar. So even if you're not in the panel, you can ask questions. Hello, Dr. Brahani. Good day. Geez, no one wants to talk to me, Emanada. We're waiting James' return. He's rebooting his computer. Apparently there's some video malfunction. Jay's here. Okay. Welcome, Uday. Is your camera on there, Uday? So we can introduce you?
Yes, I am very much here.
Okay,
John.
well, welcome. Welcome. Is your camera working? We can't see your face.
Yes, but I am just
No,
one second.
Okay, you don't have to. You just give me the option. There you go.
Okay.
Now you can introduce, you can meet the audience of Neurosurgical TV. Can you
Yes,
identify
thank you.
yourself, please? Can you identify yourself, Uday?
Okay, John. I am Uday Bhomik. I am professor of neurosurgery at Gitanjali Medical College Hospital in Udaipur, Rajasthan. It's one of the state of India.
Okay, welcome. Welcome. And you've done these webcasts many times before, right?
Yeah, we have been talking many times before also.
Good.
And I
Welcome.
admire, John, your all efforts to make all the neurosurgeons united one umbrella.
Oh yeah, it's fun. It's fun. I hope someday to come to Pakistan and to meet you guys and take this show on the road.
Thank you, John. Thank you.
Okay, nice seeing you. How about Dr. Brahani? How you doing? We're waiting for James to come back.
Yeah, good afternoon here, John. How are you?
Good. Can you introduce yourself? You don't have your live camera on, right?
Yeah, that could be because I just want to also to ride somewhere in my car. Hello, John.
There you go.
Hey.
Okay, yeah, please
Hello.
introduce yourself. We're waiting for James to come back.
Okay, no problem. I'm Bakhtiar Burhani. I'm neurosurgeon in the Netherlands. Originally, I come from Afghanistan.
Okay, very good. James is back. So you
Nice.
ready to roll, James? Did you test the video? Are you ready, James? You're muted, James.
Okay, sorry.
Okay, that's all right. So is the video okay?
Yeah, I think so. It's
Okay,
fine.
let's go. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have another in the series of 6 webcasts, the art of brain surgery masterclass with James Liu. And today he's going to be talking about the art of the clip achieving mastery of aneurysmal clipping in the endovascular era. This is the 5th of the series, and welcome, James. It's all yours.
Great. Thank you, John. Thank you for that kind introduction. Let me go ahead and share my screen. Okay, can you see my screen?
Yes, perfect.
Okay, terrific. Well, it's a great pleasure to present this as the 5th installment of The Art of Brain Surgery. Today, we're going to talk about aneurysm clipping and the art of the clip. And how can we achieve mastery and maintain proficiency of clipping techniques in the endovascular era? So I'm going to refer to these three books. I think these are three books that are very useful for any neurosurgeon or aspiring neurosurgeon in training in terms of understanding the surgical anatomy and understanding different clip techniques. So I'll refer to these books throughout my talk and reference their illustrations. Aneurysm surgery is becoming a lost art, and largely due to evolving technologies and endovascular techniques. And the number of aneurysms being treated with open strategies continue to decrease, and the work hour restrictions in terms of neurosurgery training continues to be a force that decreases our experience in learning how to do these. And I think as a result, there's fewer and fewer experienced vascular neurosurgeons who can perform advanced level open surgeries. And so it's becoming a lost art. So how can we preserve the craft? As we know, not all aneurysms can be treated endovascularly, and not all aneurysms should be treated endovascularly. So some of them will require open treatment, and some patients may be better having an open treatment. So in some of these aneurysms who have failed endovascular treatment may also need a bypass strategy. So that's very important as well. So it's important to master these open techniques so that we can provide the best outcome when we do have to choose an open approach. So how can we achieve mastery? I think these are the 4 H's that you may have heard. You have to have good hands, good dexterity and technical skill. You have to have a good head on your shoulders, be able to have a good strategy, good judgment. Sometimes we have to be creative and think outside the box. You have to have heart, which is the grit and perseverance and striving for perfection. And the last H is hours. You have to spend many hours to develop experience, develop surgical caseload under your belt. And with work hour restrictions, this can be challenging. So we have to find alternative ways, such as types of rehearsal or simulation, sometimes mentorship, going and observing people who do these surgeries at a high level, watching their videos. And there's something to be said about observation, but a deep, engaging observation where you really immerse yourself as the student and put yourself in the driver's seat as you're observing and predicting the next move, or asking yourself, how would I be doing this? And that's deep observational learning. As you know, Malcolm Gladwell has wrote this popular book called Outliers, where he says it takes about 10,000 hours to become an expert, but it's not just 10,000 blanket hours, it's 10,000 hours of deliberate practice. And this is very focused time so that each hour becomes meaningful. So let's go over some techniques. When we're talking about aneurysm surgery, I think especially if you're starting out, exposure is everything. So you want to maximize your exposure. I know some colleagues have advocated for a minimally invasive eyebrow keyhole approach. And although some aneurysms can be treated this way, this is probably not how you want to start. You want to start by setting yourself up for success, maximize your opening so that you have variable angles of attack. So you're not limited by the bony opening in terms of the trajectories you can take to get to your target. Interfascial dissection from arterional orbitozygomatic type approaches are very important to preserve the frontalis branch of the facial nerve. You have to maximize sphenoid wing drilling And the four endpoints that I tell my trainees are, you want to visualize a flattened orbital roof, lateral orbital wall, and you want to be able to visualize the anterior temporal tip. And this is very important because you don't want this overhang of the lesser wing of the sphenoid to obstruct your view. And you want to get all the way down so that you visualize the meningo-orbital band. And these are the four endpoints to maximize your sphenoid wing drilling. We also want to maximize our intradural aneurysm exposure with wide splitting of the sylvian fissure. You want to drain CSF so you have maximal brain relaxation. And in a ruptured case, in a tight brain, sometimes the ventricular drain is not enough. And if it's a aneurysm that's not an ACOM, I advocate for early opening of the lamina terminalis. It will quickly relax your brain and give you a much better situation to expose your aneurysm. Gyrus rectus or ACOM exposure, I think, is very important, very useful technique. And for paraclinoid aneurysms, optic nerve unroofing and intraclinonectomy is a very useful technique as well. And we'll show you some examples of this later on. Another useful strategy is dividing the temporal bridging veins at the sphenoparietal sinus. This allows you a pre-temporal exposure, so you can mobilize the temporal lobe posteriorly. And this really helps to visualize the tentorial incisura, and it gives you this beautiful lateral projection or lateral trajectory to PCOM and also ophthalmic artery aneurysm. So wide splitting the sylvian fissure, this is very important. Remember that the sylvian veins should err on the temporal side. And let's talk about MCA aneurysms first. When we prepare for aneurysm clipping, I advocate studying the 3D images in addition to 2D images, because with the 3D, it really allows you to have a mental rehearsal, a guided imagery, so that you preoperatively visualize in your mind's eye what you're going to see at surgery. And this allows you to anticipate what kind of clip configuration you can use. Now, there are many so-called virtual reality systems out there on the market, and they are very expensive. Not every program, institution, or hospital can afford it. But if your angiography machine or software allows you to do 3D reconstructions, this is a nice cost-saving strategy, which I actually use, where you just take your information from the 2D and you can import it into the 3D workstation, and it can generate these 3D models, and then you can cut out the noise, focus on the target at hand, and you can rotate it so that you can understand the anatomy. And in this case, there's triplicate A2s here. So this is important anatomy to visualize. And this allows me to decide which side to come from. So in this case, this was a wide-necked ACOM aneurysm ruptured. And you can see, if I come from the left side, I have an ipsilateral A2 here, and then another A2, and then the triplicate A2 is a little bit more difficult to see. But I would have to use a fenestrated clip technique to clip this aneurysm from the left side, which is not unreasonable. But if I come from the right side, look how the aneurysm is much more favorable and a little bit technically easier to clip. You may not need to use a fenestrated clip technique, but the exposure of the neck is a lot more well visualized. And so that is indeed what I chose, coming in from the right side. And you can see here's the view. Here's the aneurysm above the optic chiasm. Here's one of the A2s. This is the neck, and here's the clipping. And here's the post-op angiogram. You can see complete occlusion and preservation of the triplicate A2s. So I tell my residents that when you come into the operating room and you're doing an aneurysm clipping, whether it's ruptured or unruptured, you have to think of yourself like an airline pilot, and you need to go through a pre-flight checklist. So I always go on the back table, make sure every instrument that I need for this operation is prepared. The last thing you want to do is you're under the microscope, your dura is open, and you're opening the arachnoid, and something happens. Your aneurysm ruptures, and you haven't even prepared any kind of temporary clip or emergency clip, or even having your emergency suctions working. And the last thing you want to do is have people in the room panic, and you're unprepared to deal with an intraoperative disaster. So think of yourself like a pilot. Your job is to land the plane safely with all the passengers on board. So some general principles: neuromonitoring, establish proximal as well as distal control, because sometimes you have to shut down the aneurysm and trap it if you have disastrous intraop rupture. And once you shut off the flow, you can have your way with the aneurysm. But you have to have brain protection, burst suppression, neuromonitoring. And so be prepared to temporary clip. I have a very low threshold to temporary clip, as long as you know how to do it properly. Again, pick out the clips before you even open the dura. Pick out your temporary clips that you're going to use. Pick out an emergency clip that you may need to stop the bleeding and clip the aneurysm. And always be prepared for the worst. Always be prepared for the dreaded intraoperative rupture, and have in your mind's eye, how are you going to deal with it if it were to happen? So if you mentally prepare yourself for, it's like disaster preparedness. If you've mentally prepared yourself, rehearsed it, so when the time happens, it's a lot more manageable to deal with. Try to use the simplest configuration if possible, but sometimes you have to be creative and think outside the box with more complex configurations, such as tandem clipping, stacking using fenestrated clips. Sometimes you have to open the aneurysm and do a thrombectomy for larger, giant thrombosed aneurysms. Sometimes you need a bypass strategy, and try to avoid the intraoperative rupture or neck tear, but if it happens, be prepared to deal with it. One common mistake is subfrontal retraction, especially on a down-pointing ACOM aneurysm where the dome is stuck to the chiasm. I've seen people elevate the frontal lobe, sometimes gently, sometimes too aggressively, and the neck tears and you have an intraoperative rupture. Be careful of the lateral temporal lobe retraction for laterally pointing PCOM or even MCA aneurysms where the dome is embedded into the brain, parenchyma. In those cases, I generally make a small corticectomy to release the dome of the aneurysm so that you have brain protecting the rupture site. So you leave a little bit of brain on the dome of the aneurysm. Temporary occlusion, adenosine pause is a useful strategy. If you can't get temporary control, it temporarily stops the heart to drop the blood pressure and the aneurysm can deflate. And then suction decompression for giant aneurysms, very useful strategy. I'll demonstrate that in a few cases. Here's a wide-necked ACOM aneurysm. You can see very large and wide neck incorporating both A2 vessels. Difficult one to treat with coiling. So here we're using a tandem clipping technique. So what is a tandem clipping technique? It's where you clip it in 2 or maybe 3 steps rather than a single clip. So if you try to clip this in a single clip, you'll most likely stenose the A2 outflows. So you want to take it in 2 bites, if you will. So you use a fenestrated clip. Sometimes to fenestrate this ipsilateral A2, but sometimes you don't need it to fenestrate. But the fenestrated clip is useful because it has a very much higher closing force. And when you use the fenestrated clip, you want to focus on clipping the distal neck first and preserving that distal contralateral A2 vessel. And then you leave a little remnant on the proximal side, leave a little bit of a neck. So you don't over clip it, you slightly under clip it. And then with the second clip, you come in with a smaller clip and then clip off the remnant from the backside. And so that's called tandem clipping. And that's a useful technique for wide neck aneurysms. I often use it for MCAs and also for basilar apex aneurysms. So here's the post-op angiogram, excellent flow and intact patient. So some clipping pearls. Everyone has a tremor, even senior neurosurgeons. So even at the highest magnification, our tremors get magnified. So we have to learn to stabilize our tremor. Know to where to rest your wrists, rest your elbows. I think sitting in an operative chair really helps with that. Don't obstruct your line of sight. Use bayoneted instruments. Make sure you triangulate your hand so that your knuckle or portions of your hand are not obstructing your line of sight to the deep targets. Be mindful where the tip of the blades are. You don't grab the perforator. So when you're looking at the clip, you have to think about all aspects and dimensions of where the clip blades are. As the blades close, it often will expose more of the anatomy. And sometimes a pilot clip, your first trial clip, may not be perfect, but once you close down the aneurysm and you're able to inspect, you'll be able to see more of the anatomy and then make adjustments to make that perfect reconstruction. Learn to use your non-dominant hand. Oftentimes non-dominant hand is our suction, where we use it as a dissector or a retractor, constantly checking on perforators. So when you're clipping, that non-dominant hand is doing a lot of the work. And I'll show you that in a few examples. But also use your non-dominant hand to clip in some cases where the angle is more preferable. Your clip applier should be used in a multi-directional fashion. And again, the first clip may not be the final clip, but it can help in defining and understanding the anatomy. And sometimes you have to be ambidextrous and clip with your left hand. So MCA aneurysm. This is an example of a common scenario, MCA aneurysm rupture, a big clot, some midline shift here, tight brain. What do you do? I've heard some people advocate for emergency coiling and then taking them for an emergency decompressive craniectomy. I think that's a little absurd because you're losing time. Time is brain, and you want to decompress the brain as soon as possible. So you need to do an emergency craniectomy, evacuate the clot, take care of the aneurysm, and if needed, you can make a decision whether or not to leave the bone off, depending how tight the brain is. So here's the video. We're done a terional craniotomy and a small temporal corticectomy where we're evacuating the clot. Now, when you evacuate the clot, you want to evacuate just enough to relieve some pressure. Don't untamponade the aneurysm. And now we can go and open up the arachnoid cistern to relieve CSF. I'm opening the lamina terminalis early here. This is an MCA aneurysm. There's no ACOM. So even though we have a ventricular drain, opening up the lamina terminalis early is much more effective to give you quick relaxation of the brain. We can now get into the sylvian fissure, which we were not able to before. And there's the long M1 segment. Here's the M1 segment coming in. This is a left-sided approach. You can see the 3D to give you a reference. Here's the aneurysm, defining the neck of the aneurysm. And you can see where the rupture point is. It's where the clot is situated. And you can see this is a very bulbous, wide-necked aneurysm. So under burst suppression, I'll put a temporary clip on the M1. And now I'm going to use a tandem clip technique where I use a fenestrated clip. And I'm not going to clip all of the aneurysm. I'm only going to focus on clipping the distal neck. So here is the contralateral inferior branch of M2. So I want to preserve this M1, M2 takeoff. You see that? I want to focus on reconstructing that distal neck, and then the proximal neck, which is here. This is where the M1 becomes the superior M2 branch. So we'll sneak in with a smaller clip and finally reconstruct this aneurysm. So this is an example of the tandem clip technique where you're taking it in 2 bites, and especially in this aneurysm, because this is a partially calcified, partially thrombosed aneurysm. And if you tried to clip this in a single clip, you're most likely going to stenose the M2 takeoff. And this is a ICG combined with a fluorescein visualization. And you can see there's no further filling in the aneurysm. And look, the brain is really decompressed. You can see the brain is below sea level. And so in this case, we can put the bone back on safely. And here's the final view. You can see post-op angio neurologically intact. I'm showing this case. This is a anterior temporal branch aneurysm here. And patient here was had a subarachnoid hemorrhage, but was in rather neurologically intact, awake and talking. So we don't need to put in a ventricular drain right away. But when we take them to surgery, we can put it in at the time of surgery. And this shows you one strategy how I do it. And so you can see this, the dura is open. It's quite hemorrhagic here, subarachnoid hemorrhage. Opening up the sylvian fissure here. And we're going to find the distal MCA branch. And so here is the neck of the aneurysm. We're going to define the neck of the aneurysm. Here's the MCA trunk. And then here's the anterior temporal artery takeoff. And here's the neck of the aneurysm. We're using a right angle probe, ball tip probe. We're defining the neck. There's the distal neck. Here's the proximal neck. Now, because I'm using a right angle probe, this gives me an idea of using a angled, side angled clip. So ergonomically, this is useful. I can sit comfortably where I am and just come in with this angle to come across the neck of the aneurysm. So pretty straightforward technique, but you want to make sure your clip blades don't grab the deep side of this distal anterior temporal artery takeoff. And you can see that's nicely preserved here on the ICG. And we can now open the dome of the aneurysm to confirm complete occlusion. And this is a ruptured case, so I often will always open up the lamina terminalis and open up the membrane of Lilliquist simultaneously, as this can decrease your chance of needing a permanent shunt in most cases. So here is the lamina terminalis. I'm sorry, this is the membrane of Lilliquist in the carotid oculomotor triangle, or optical carotid cistern in this case. And it's nicely opened here. And the patient ended up not needing a VP shunt. Here's the post-op angiogram, no residual aneurysm here. So a more challenging MCA aneurysm, this is a
Good
patient.
morning, John.
Hi,
Estoy
good
asistiendo
morning.
puntualmente a la conferencia tan excelente de James Liu sobre cirugía vascular, que es uno de mis afectos. Me ilustra mucho y me sirve mucho para ayudar a mis pacientes. Gracias.
Thank you. So here is another more difficult aneurysm. This is a ruptured MCA, a large wide-necked aneurysm who underwent coiling. And you can see here's the occlusion of the aneurysm. There's a small residual at the base. And over time, the aneurysm began to recur. And so she now is at risk of a recurrent rupture. And so what are your options here? You know, should we bypass this or should we try to reconstruct this? And so you have to prepare for both. So here what we've done is we're prepared to do a bypass, but you always want to try to see if you can clip it first because it's a much more simpler technique. So here is the M1. Here's the M2 vessels. So we're going to temporarily occlude the M1 and then we'll try to clip the aneurysm. And you can see what happens here is that the aneurysm is packed with coils. So it's pushing the clip down and stenosing the M2s. So the decision now is to open the aneurysm and do a thrombectomy and coil extraction. So we trap the aneurysm and then you open up the dome in the aneurysm and you have your ultrasonic aspirator ready. You have to make sure this device is ready to go because if it's not working and you're occluded, you're increasing your occlusion time and risking ischemia. So you want to have everything ready before you open and commit to the aneurysm. And once we've opened it, we did a thrombectomy with an ultrasonic aspirator and I got out enough coils and mobilized it to the side so that I can put in a clip. You don't want to waste too much time trying to extract all the coils. You just need to move them aside and do a tandem clip here. Again, for these thick-walled aneurysms, you don't want to overclip it. So notice how this M2 vessel is blue. There's no Doppler signal. This is occluded. So you now have an M2 occlusion. You have to inspect what's going on. If I take out this clip, thinking it would stenose this, so it was still stenosed. So now I have to open up the aneurysm, but I've left this temporary clip open because I want it to back bleed. So now you can see there's an intimal flap occluding this lumen. There's some debris here that needs to be cleaned up some more. So now I get some backfilling. And now I'm going to use micro scissors and just do a endarterectomy. Use heparinized saline to clean off the lumen. And now I'm going to re-clip it again. And then use a tandem clip technique here with a fenestrated. Take off our temporary clips. And you can see now the Doppler is confirmed that there's good signal. And we'll go ahead and excise the rest of the coil mass because now we're clipped. Now we have all the time in the world. We're not under any temporary occlusion. And I'm going to do a clip reinforcement with our tandem clip. Now it's important on these aneurysms not to over clip it. You don't want to get the most perfect reconstruction because these are thick walled aneurysms. If you try to make it too perfect extraluminally, it will be imperfect intraluminally and potentially stenose your M2 takeoff. So remember to underclip it. We'll put a little bit of cotton wrap around the neck. And here's the post-op the angiogram. You can see excellent reconstruction of the MCA. There's no further filling. Here's an example of a small blister-like aneurysm. But even in a blister-like aneurysm, you have to be creative. And here we're doing a picket fence construction because a single clip was not able to clip this adequately because the aneurysm was incorporating the bifurcation on the backside. And that's why we started to clip it in this type of fashion. There's a small remnant right in the middle of clips 1 and 2, and we'll take care of that. You can see this takes care of the backside dome with that fenestrated clip, and then just stacking it vertically to reconstruct this aneurysm. And there's the ICG, so you can see it's a beautiful stacking picket fence to reconstruct this MCA bifurcation. This is a technique that I call the suction persuasion pull-through technique. This is a ruptured MCA. We've exposed it here, the Sylvian fissure. We'll put a temporary clip on the M1. And I'm going to do a tandem clip technique here because it's wide-necked. And what you'll see is the backside here looks very good, nicely reconstructed on the backside. But you got to look on the front. You see how the M2 is preserved? But look on the front side. There's still a bulbous residual neck here on the front side. So I'm going to gently open the clip blades and use my suction to pull through and persuade the residual neck of the aneurysm through the clip blades. And once it's optimally positioned, I reclose the clip blades so that I can bring and pull through that residue of the aneurysm. Check that the M2 is nicely open. And I'll come in with a small clip now to complete the tandem clip reconstruction. And nice filling of the M2s and M1 on the ICG. Looking on the front side as well, you can see it's nicely reconstructed. And you could see the suction persuasion pull-through technique. It's a technique I often use to make the adjustments. So let's talk about ACOM aneurysms. There's generally 4 types here in different directions. The inferiorly projecting one, beware of subfrontal elevation. You can see subfrontal elevation here resulted in a small microaneurysm here that was stuck to the tuberculum that started to rupture, and luckily we took care of it with a small clip. Again, here's an inferiorly pointing one. You see how they're often stuck to the chiasm? There's no need to dissect it off the chiasm. You could probably result in visual loss, but you want to be able to define the neck. And in these cases, defining the neck and coming in with a straight clip blade is often the strategy here. Anteriorly pointing are very similar to inferiorly pointing. They're just slightly more superior. Here you can see this is the A1 coming from the right side. Here is the ipsilateral A2 going this way, and the contralateral A2 and the ACOM are going in this direction. So defining the neck and then coming in with a straight clip blade. This one is a little bit trickier. This is a aneurysm that was wide-necked and incorporated the A1, A2 junction. It's not so apparent on the 3D, but you'll see here in a minute. So we're opening up the Sylvian fissure widely, keeping the Sylvian vein on the temporal side, using sharp dissection. And as we get down to the carotid cisterns, we'll open up the arachnoid over the optic nerve and the carotid artery. and we'll do a gyrus rectus resection here to get a better exposure of that A1, A2 junction. This is a technique I frequently use for ACOM aneurysms, and you could see we can now visualize the aneurysm here. So we'll use a temporary clip, and you can see this aneurysm is pointing anteriorly. So we're looking for the contralateral A1 coming across the other side. And because this is a wide neck aneurysm, I'm going to use a fenestrated clip, not because I need to fenestrate a vessel, but because it has a higher closing force. And I like the way the fenestrated clip blades close, because instead of this motion, it's got this motion. And so it's easier to see and visualize, in my opinion, when I'm using a fenestrated clip. And then I'm focusing on all aspects of the clip blade, the tips of the clip, making sure I don't grab a distal A2 or A1 or perforator. And I'm going to reinforce this with another clip stacked on top. And a small remnant here at the takeoff of the neck. We'll take care of it with this small mini clip to take care of the residual. So here's the final view. And then here is the ICG showing the patent recurrent artery of Hubner. Here's A1, A2, and no further filling of the aneurysm. And then we'll go ahead and open the dome. And here's the final view. Here's the post-op angiogram. You can see nice reconstruction and filling, and the patient was neurologically intact. Superiorly pointing aneurysms, these are a bit more challenging because the ipsilateral A2 is often in your way, and in these cases, you have to be prepared for fenestrated clip techniques. Here's one example. This is the example where this aneurysm was incorporating the ipsilateral A2. Here we've done a modified orbitozygomatic. I prefer taking off the orbital rim here. It just gives you that extra room. So here is the A1, this is the A2, this is the A1, A2 junction. And then here's the ACOM. And so here's the aneurysm. You see how the aneurysm is incorporating this A1, A2 junction. So we're going to use a fenestrated clip. And this time we're using it to fenestrate the ipsilateral A1, A2 junction. So I like to use the 5mm fenestration as opposed to the 3, because it gives you a much better room. So I have to adjust this clip because there was a remnant on the ACOM. You can see there was bulbous aneurysm. So I'm just making an adjustment so that the clip blade is now sitting right into that ACOM to perfectly reconstruct the communicating going to the contralateral A2 that you see there in the interhemispheric fissure. This is the contralateral A2 here. You see that? So here's A2 and here's A2. And now I'm using the clips to create the tube of the ipsilateral A2. You can see how I'm just stacking them. You can see there's still a remnant of aneurysm. Now we'll come in with a third fenestrated. So this is a stacking fenestrated technique. So I'm recreating the A2 vessel on the ipsilateral side. You can see these fenestrated clips have reconstructed that. The ACOM here is patent. You see how the ACOM is patent here? And ICG shows nice filling of this A2. You want to make sure the contralateral A2 is patent, as well as the ACOM. Here's the other A1. And that's the final view. Here's the post-op reconstruction. You could see beautiful reconstruction of this ACOM and the stacking fenestrated strategy to create that tube. Posteriorly projecting on the backside, these can be challenging sometimes, and you have to use sometimes angled clips. Here is one that is a triplicate ACOM. This was a very rare variant, but here, if you look on the 3D, there's 3 aneurysms on this ACOM complex, and there's 3 A2s. So having that 3D model really prepares you on how to clip this complex aneurysm. So careful study. I've labeled this as aneurysm 1. Then we'll deal with aneurysm 2, and then lastly we'll deal with aneurysm 3. You can see that here in the intraoperative view. Here's the the right A1 and A2 junction. Here's the ACOM, and so you'll see how this is done. I call this the 3-headed dragon. Here are those aneurysms that I mentioned. So here is the clipping of the first aneurysm, and we're going to use a fenestrated here for higher closing force, but to fenestrate the A1, A2 junction. And we'll clip the remnant here with a straight clip just on top of it and stack it with the next one. So that takes care of aneurysm 1. Aneurysm 2 here, we can use an angled clip. There was a brief intraop rupture that you see here. We can clip that with a bayoneted clip. And then the third aneurysm is this bulbous aneurysm right at the ACOM. And then we'll take care of that with the bayoneted clip. So the ICG and the post-op CT angiogram shows excellent reconstruction of all those aneurysms. And you can see in the post-op angiogram is intact. Patient's neurologically intact. Here's an example of a posterior pointing aneurysm. This is one I treated some time ago. Here you can see this is a left-sided approach. Here's the left A1. I'm sorry, here's the contralateral A1. Here's the left A1 and A2 junction. This is the communicating artery here, and this is the aneurysm pointing posteriorly. So to really expose that, you have to do a very good gyrus rectus resection. And in this case, because of the angle of the aneurysm, you can come in with a straight clip and then grab the wide-necked aneurysm here. This is a case I did recently, this past week. You can see this is a patient with Marfan syndrome and had a very tortuous aorta and had a previous aortic dissection. And so my endovascular team felt that this was very risky for endovascular strategy. So you could see it's got a wide neck, a large dome, and the dome is pointing away, but it's fed primarily by the left A1, A2, A1 feeder. So having this 3D is very useful because if you rotate it into the surgical view, this is the actual surgical view of the aneurysm. So this aneurysm is very difficult to see coming from the left side, but coming from the left side gives you the best proximal and distal control should the aneurysm rupture. So even though this is a difficult surgical view, I ended up choosing a left-sided approach because of proximal and distal control. But understanding this anatomy. So here is the video. You have the 3D above for reference. Remember the surgical views on the left side. So we're opening up the Sylvian fissure widely and opening up the arachnoid over the optic nerve. And there's the chiasm. And we'll go ahead and do a gyrus rectus resection subpially until we see ipsilateral A2, open up the arachnoid, preserve these small perforators. This perforator is coming from the A2. We don't know if it's a recurrent artery of Hubner yet. So there's the aneurysm. There's the contralateral A2 right here. And so all these small perforating vessels we're going to preserve. There's the backside, the neck of the aneurysm here, the dome of the aneurysm. So we're going to define the neck using this right angle ball tip probe. There's one neck of the aneurysm. Here's the second neck of the aneurysm. And then we're coming in this direction. So we can put our clip blades like this, or we could put our clip blades in this direction. And so that's indeed what we decided to do. So we're going to put a temporary clip under burst suppression on the ipsilateral A1. And then I'm going to use a fenestrated clip to reconstruct this neck and reconstruct the A1, A2 junction. We make sure that the clip blades go all the way across the neck. We did an ICG, which showed that it was occluded, but then when we punctured the dome of the aneurysm, it was still alive. So before you puncture the aneurysm, always have another clip ready. And so we had this 5 millimeter right angle fenestrated clip ready to occlude the aneurysm. And on the ICG, there was a small filling on the backside. So now we'll reinforce that posterior part of the neck with a small 3 millimeter right angle fenestrated. And now you could see reconstruction of that A1, A2 junction. Recurrent artery of Hubner is intact, very important. And that's the final reconstruction. Here's the post-op angiogram. You can show excellent filling of that A1, A2 junction. There's no filling of the aneurysm, and you can see this is our clip configuration. So PCOM aneurysms, beware of the PCOM knuckle. Always look for the PCOM knuckle. Here is a right-sided PCOM aneurysm. We're dividing that temporal bridging vein right at the sphenoparietal sinus. And I like this technique because it allows you to mobilize that temporal lobe posteriorly. So you have that pretemporal exposure. Here is the aneurysm. This is the PCOM knuckle. This is a fetal PCOM, very large PCOM. And here's the anterocoroidal takeoff. So it's very important to visualize the anterocoroidal before you apply the clip, because occlusion of the anterocoroidal is unforgiving. It almost always results in very dense hemiparesis. So this is a pretty straightforward clipping. Here we're using a bayoneted clip. I often will do that for PCOM. There's the third nerve. You can see the third nerve right here. And here's the fluorescein injection complementary to your ICG angiography. So the choroidal is intact. The PCOM is intact. And an endoscope can be useful as well, just to inspect your clip reconstruction. You can see the PCOM nicely here. Here's the PCOM, here's the third nerve. Here's another example. This is another laterally pointing PCOM. These are a little bit more straightforward. These PCOMs sometimes are going to be either infratentorial or supratentorial. If they're supratentorial, sometimes the dome can be embedded into the temporal lobe, so beware of that. But this is a ruptured case here. We're opening up the arachnoid membranes, opening up the sylvian fissure. And here's the neck of the aneurysm. Here is the PCOM takeoff. And so the aneurysm has ruptured here. You can see once the aneurysm is ruptured, you want to keep your suction in position. Don't remove your suction. You'll lose your position with the aneurysm. So keep your suction in place if the aneurysm ruptures, and then go ahead and close the blades here. Here we're trying to preserve this PCOM. You can see this distal PCOM here, so making sure the clip blades do not occlude that PCOM vessel. And there's the final view. So ophthalmic paraclinoid aneurysms, these can be quite challenging. You have the intraclinoid process in the way. So often you'll need a intraclinoidectomy and optic nerve unroofing to visualize this. When we do these intraclinoidectomies, I like to use a hybrid technique where I come in extradurally first, cut the mini-orbital band and peel the dura propria off of the cavernous sinus. I can then expose and unroof the optic nerve canal first, and then visualize where the clinoid is going to be, which is between the optic canal and the supraorbital fissure. You then decompress the clinoid, and the most distal part is hidden quite deep. And so this last portion I'll remove intradurally, and that's the hybrid technique in some cases. And of course, when you remove the clinoid process, you'll expose the clinoidal segment of the carotid artery, and this can be useful in some cases where you need proximal control. And here's an example from Dr. Lawton's textbook on doing the intradural clinoidectomy. So I like to do a hybrid technique where I remove approximately 90% of it extradurally, and the remaining tip we'll do under direct visualization intradurally. And then remember to open up the optic nerve sheath and to recreate the distal dural ring. So when you're clipping ophthalmic artery aneurysm, I think the side curved clip is a useful strategy, because the side curved clip allows you to make your clip blades as parallel to the parent artery of the ICA as much as possible. So the way you do this is you come in laterally with that pretemporal projection after dividing the bridging veins of the sphenoparietal sinus. We'll come in with a side curved clip. So the clip blades go across the neck. And as you're clipping and closing the blades, you rotate your hand anteriorly so that the clip blades point more parallel in the direction of the ICA. And here's the final ICG showing this clip reconstruction. You can see how the dome here is quite embedded into the optic nerve. Here's a patient with multiple aneurysms. She's got an ophthalmic, an MCA, and a contralateral superior hypophyseal on the other side. So if you come in from the left side, you can treat all of these aneurysms in one sitting. So here we're cutting the meningoorbital band, peeling off and unlocking the cavernous sinus. And then we're going to do our extradural clinoidectomy here. Unroofing the optic nerve. Beware of the optic nerve. Don't drill into it. So you have to unroof the optic nerve first. And then wide splitting of the sylvian fissure. There is the MCA aneurysm. We're going to define the neck of this MCA aneurysm. Look how there's a little blister here at the bifurcation right here. You see the small blister? So there's two aneurysms on this complex. So under temporary occlusion, we'll put the we'll clip this MCA aneurysm first. We'll take care of it with a straight clip. Looks pretty straightforward, and that takes care of this MCA. Now with the blister, we're going to use a small 3 millimeter clip, and this mini clip just grabs the blister and closes that off. So I find that 3 millimeter clip very useful for these small blisters. And now we're going to open up the cisterns. There's the contralateral superior hypophyseal aneurysm. You can see it right in the prechiasmatic cistern. And so this allows us to come in from the contralateral side with the curved clip and take care of this hypophyseal aneurysm from the contralateral side. So fortunately, the anatomy here is favorable for that. You have a nice prechiasmatic space. And now we'll go ahead and open up the dural sheath of the optic nerve ipsilaterally. And look for this ophthalmic artery aneurysm. After we define the neck of the aneurysm, the ophthalmic artery takeoff is more proximal. You see how opening up this dural sheath is very critical. And here's an intraoperative rupture, unfortunately. But you see how I keep the suction in position? The minute I remove my suction, I lose my footing, and it's going to be hard to regain that position. So keep your suction in position. Don't panic. Have your clip ready, and just clip the aneurysm to get it to stop. Here's the final view, fluorescein angiography, showing filling of the ophthalmic artery there, and filling of the MCA reconstruction here. And then the contralateral hypophyseal aneurysm is also clipped. You can see no filling here, and the ophthalmic artery takeoff is nicely patent. And there's the hypophyseal aneurysm, no longer filling. Let me switch to another part 2. Just have a few more slides. Hold on one second. Okay. Can you guys see part 2?
Yeah.
Okay. So these periclinal aneurysms can be challenging. These are largely treated with flow diverting technologies these days, but in some cases you must be prepared to clip them. And Professor Sugita helped us understand these anatomy better with fenestrated clip techniques. The technique described by Dr. Bajer and Sampson, the Dallas technique, retrograde suction decompression, is very useful as well to help deflate these aneurysms. And the way you do this is to expose the carotid in the neck, ligate the proximal ICA, and then put a needle in the ICA to retrograde decompress and suction, deflate the aneurysm as you clip it. So this is an example where we used a modification of this technique. This is a giant carotid ophthalmic artery aneurysm with visual loss. So we do an incision in the neck to expose the neck. There's the carotid bifurcation. And here's the craniotomy. So we're going to go ahead and open up the meningoorbital band, and we're going to peel the lateral wall of the cavernous sinus away to do an extradural clinodectomy. So here we're unroofing the optic nerve canal. And then we'll drill off the rest of the clinoid process here. So after we take off the interclinoidectomy, we'll go ahead and open up the Sylvian fissure. And then there's the optic nerve here. You can see how it's under a stretch by this aneurysm. We'll then open up the dura over the subfrontal area so we can open up the falciform ligament. And when you open up the falciform ligament, you should open it on the lateral edge instead of the midpoint of the canal, because that's where the nerve is the tightest. You'll have a higher risk of injuring the nerve if you try to open up the falciform ligament in the middle. So you should open it on the side. And now we're going to define the distal dural ring. And here I'm putting in a stitch to retract that dura to give us better exposure. And so here's the neck of the aneurysm. We're going to do a modification of this where I put a temporary clip on the external and put a clip on the common carotid instead of the internal. And we'll put a clip on the distal ICA, distal to the aneurysm. And we'll put the needle in the common carotid so that we don't injure the internal carotid. And we'll put it to suction. The suction decompress the aneurysm. And you can see the aneurysm is now deflated. I can now define the neck of the aneurysm from the ophthalmic artery takeoff. Here's the ophthalmic artery. So I can define this neck right here and come in with a side curved clip, as we do in a lot of these ophthalmic artery aneurysms. And then visualize the clip blades. You see I'm using my suction to sweep and visualize the anatomy better. And we'll go ahead and close that. And take out the needle. And we'll close this with a single stitch. And then we'll take out the clip from the external. And you'll see that on the ICG, the aneurysm is still filling. But I felt that my clip blades were all the way across the neck. So why is it still filling? Well, because there's this little gap right here on the proximal portion of the clip blades. So we'll put a small reinforcement to cover that gap. I call that the thigh gap of the clip blade. And now the repeat ICG shows that it's no longer filling. So now we can decompress the aneurysm. And you can see the optic nerve is completely deflated. And there's no further filling of this aneurysm. Interestingly, there was a A1 lenticulostriate aneurysm in addition to this. And so with these A1 lenticulostriates, you have to preserve these lenticulostriate vessels. And we'll come in with a right angle clip and then preserve these A1 lenticulostriates. You can see nice filling of these lenticulostriate vessels here. And this was the outcome. She had improvement of her visual loss and excellent reconstruction, neurologically intact. I'm going to show you a variation of the suction decompression. This is a technique we published called direct suction decompression. So instead of opening the neck, if you're able to get proximal control after your clinodectomy, you can trap it and put a needle directly through the dome of the aneurysm. So here we've opened up the distal dural ring. And so after we open up the distal dural ring, we're going to define the neck of the aneurysm. Here's the distal ICA. And then here's the proximal control. So we're able to put a temporary clip on the proximal ICA after our clinodectomy, put a distal clip here. And so the aneurysm is now trapped. And then we could put a butterfly needle right into the dome of the aneurysm and begin to suction decompress it. And then reconstruct it with right angle fenestrated clips. Look how this clip blade is slipping. And that's because there's calcium in the neck. So it's going to want to slip down and occlude the lumen of the ICA. So how do you deal with calcification in the neck? Well, the way I try to deal with it is I clip the soft portions of the aneurysm. And then you leave the calcium intact. Try not to clip the calcium, but clip the soft portions around it. So you can see this is the calcium, the hard portion of the aneurysm. We're clipping the soft parts. And we're going to try to close off the dog ear here with this gentle curved clip. Beware of the anterior choroidal vessel. So here I'm trying to look for the choroidal vessel. It's right here. And it's stuck to the dome of the aneurysm. So you want to identify a perforator-free zone so that the choroidal is no longer in your way. Here's the choroidal vessel, and I'm going to put a reinforcing clip to make sure this back portion is no longer filling and that it's not going to occlude the choroidal vessel. And then we'll put some reinforcing vertical fenestrated clips here to gather this dome of the aneurysm. And we'll put a second one. Now we'll puncture the aneurysm, and you could see it's no longer filling. And we'll take off the proximal clip now. And you can see there's a dog ear right here. There's a dog ear coming lateral. And so we'll take care of this dog ear with the gentle curved clip coming from lateral to medial. So there's the final reconstruction. And we'll do an ICG shot here in a second. You could see here's the ICG and here's the filling of the choroidal vessel down here. And here's the final reconstruction. And here's the post-op angiogram. So a nice reconstruction here. Here's a giant ophthalmic that had a subarachnoid hemorrhage. This was before the flow diverting era. But there was no ACOM collaterals. So if you were to sacrifice and do a deconstructive method here, you would have a stroke because there's no ACOM. So in this case, we prepared for a high flow bypass. This was a prophylactic bypass. And so once the bypass is intact, this is an ECA to M2 with a vein graft interposition. Once the bypass is now intact, we can go ahead and safely clip the aneurysm. Just in case we weren't able to clip the aneurysm and you had to sacrifice the ICA, you have a prophylactic bypass intact. So here's the post-op angiogram. I just want to touch briefly before we conclude on some posterior circulation aneurysms. This is to expose the basilar, you really need to open up the carotid oculomotor triangle. Sometimes you do an anteroclinodectomy and posterior clinodectomy if needed to get lower on the basilar trunk. Here's an example. This is two aneurysms in the same patient with a fusiform ICA aneurysm and then a wide neck basilar apex aneurysm. And this aneurysm here was not favorable for coiling, this basilar apex. So we'll clip both in one setting here. So here we're removing the anteroclinoid process through an orbitopterional approach, wide splitting of the sylvian fissure. Here's the aneurysm you see here. Fusiform, we'll put a temporary clip proximally and then reconstruct it with the right angle fenestrated clips to reconstruct the lumen of the ICA. And then we'll reinforce it with a vertical fenestrated clip. Preserving the PCOM takeoff here laterally. And then we'll put another right angle fenestrated clip on the proximal side to make sure we got it all proximally. And so after that aneurysm is taken care of, we're going to open up the carotid oculomotor triangle. Here's the third nerve. We're going to open up the arachnoid here in this area. There's the basilar artery, and there's the basilar aneurysm. Here's the dome of the aneurysm. This is the PCOM perforators. We're going to try to preserve these. Here's the contralateral P1. So we're going to use a tandem clip technique. We're going to use a small fenestrated clip focusing on the distal neck. Here's the distal neck of the P1 takeoff. And once we close that, we'll look here. There's a bulbous backside of this aneurysm. You can see there's ipsilateral P2. There's the bulbous backside. And so we'll take a straight clip here and just grab this backside and take care of the remainder of that aneurysm. So here's the reconstruction. And then here's the final reconstruction. You can see how the basilar apex is nicely taken care of. I'm going to skip this aneurysm in, actually, I'll talk about it. This is a distal SCA aneurysm, and this is a mycotic aneurysm. It's a pseudo aneurysm. Look how the 3D angiogram shows a mushroom cloud. This is not a true aneurysm. This is a ruptured pseudo aneurysm where there's no true wall, and these are treacherous. So I felt that a Kawasi's approach would give you the best proximal and distal control of the SCA as opposed to a retrosigmoid approach. And so here we're doing the anterior petrosectomy from the Kawasi's approach. After we drill out the petrous apex, we open a dura subtemporally. And we'll go ahead and cut the tentorium to give us exposure. And when we open up the arachnoid here, you can see that it's a complete mess down there. But once we open up the arachnoid, look at this bleeding. That's spontaneous bleeding from the pseudoaneurysm. This is how treacherous mycotic pseudoaneurysms can be. And we have no great proximal control. I try to bipolar whatever is bleeding, very futile technique that doesn't work. So here we've put temporary clips, and sometimes you get lucky and you grab the bleeding site. And so now that the aneurysm is no longer bleeding, we can identify the anatomy. There's the proximal control. I find the proximal SCA, put a temporary clip there. And I find the distal SCA. So you can see how this Kawasi's approach allows you to have proximal and distal control very nicely. The retrosigmoid would have difficulty visualizing this in a deeper hole. And there's the aneurysm. There's no neck. It's a big hole. And so here we just went ahead and just sacrificed the SCA, and the patient did fine. So here's the anatomy showing the SCA vessel. This is a distal pica. It's rather wide and fusiform and not favorable for endovascular approach. How would you do this? My original plan was to potentially excise this aneurysm and do a end-to-end anastomosis. But sometimes your intraoperative observations will change your strategy. So here we did a midline suboccipital approach. You can see there's a lot of blood in the cisterna magna. And we'll open up the arachnoid widely. Here is the right pica. And then here's the left pica. And here is the fibrin clot. So we're going to do a little bit of tonsillar resection. That'll give us a little bit extra room, just like you would do a gyrus rectus for ACOM. But here I want to be able to get distal control here. So now I can get distal control, which is the loop of the pica going up towards the fourth ventricle. So here's the distal control. So now I can see the inflow. Here's the aneurysm. Here's the outflow. So you want to get proximal and distal control. And here I was planning for excision with reanastomosis. So there's the aneurysm. You can see it nicely. There's the loop of the pica. So I'm going to put a proximal temporary clip, a distal temporary clip, and there's the aneurysm. So I can expose this whole aneurysm now. And after I look at the aneurysm, I thought maybe I can try to clip it first, right? It's always the easier strategy. So here I've deflated it with a form of suction decompression. It's actually just puncture decompression. So I start with clipping the distal neck, and then using a picket fence stacking technique, I was able to reconstruct this aneurysm. And then I think I take off the temporary clips to reestablish flow. And now that the aneurysm is clipped, I can dissect it from the rest of the brain clot. And then I'll put one more here to reinforce. And there's the reconstruction. So I was able to reconstruct this wide fusiform type neck and preserve the flow of the pica. So I was able to do this without having to excise and reanastomose. So sometimes you prepare for the most challenging, but always try the more simpler technique. So here's the post-op reconstruction, very nice reconstruction of that pica. This is another terrible subarachnoid hemorrhage. You can see in the 3D CTA, this is a pica aneurysm. Here's the contralateral loop of the pica. Now this one's tricky because this was actually fed by an ICA-pica variant. So ICA-pica variant is different because this ICA-pica variant is now running in the, it's no longer in the subarachnoid space. It's on the, this vessel of the pica was on the surface of the cerebellum. And you had to recognize that. And you had to do a corticectomy in the cerebellum to find the aneurysm, to clip this ICA-PICA variant of a distal pica aneurysm. So here's the post-op angiogram. This confirms, you see, this is the ICA. This is the ICA-PICA variant, and there's the clip blades. This is a dissecting pica, ruptured aneurysm. You can see it's got a corkscrew roller coaster loop here. So here this is not amenable to clipping or endovascular. So the strategy here is to revascularize the pica territory. Here we're going to do a side-to-side pica anastomosis to revascularize the ipsilateral pica. And then we're going to go and trap the aneurysm at the end. So here's showing the techniques of doing a side-to-side anastomosis. We make our arteriotomies at 2 and 10 o'clock. And then we'll do our anchoring stitch. And then you're going to suture on the inside to inside on the back side of the lumen first. And then once you get to the end, I like to tie this off first instead of one continuous stitch, because if you have a bad stitch, you have to redo the whole anastomosis. So I like to close the back side first, tie it off, and then start a new stitch to close the front side, which I think is a lot less stressful. So then we'll reestablish flow, taking off the distal temporary clips and showing nice flow through the pica anastomosis, complementary with the fluorescein injection. And then we can go ahead and trap the aneurysm. So here we're going to the proximal pica, and we're going to trap that aneurysm here. And so here's the final view. You can see the pica anastomosis here is intact, and the aneurysm is now occluded. And another view here showing the nice pica anastomosis in the lower cerebellum. So in conclusion, I think there still remains a role for open surgery for aneurysm treatment. The challenge is how to maintain proficiency and achieving expertise, especially with the time constraints and the lesser volume of cases available. So we have to preserve the craft. We have to be dedicated and committed. I think mentorship is very important to improve microsurgical and skull-based technical skills. And I think in this era, we really have to become experts in bypass strategies, as this will play an emerging role for aneurysms that are not amenable to either coiling or clipping. Thank you for your attention. I'll be happy to take any questions.
Okay, thank you very much, James. Thanks very much for your time. I'm sure we have some questions. Maybe we'll start with Harshad Parekh, the neurosurgeon from India. Harshad, are you there?
Hi, John. Hi, James.
Welcome.
Again, meeting. Wonderful presentation, and you have covered the whole spectrum of aneurysm surgery and demonstrated various ways of tackling these aneurysms. Superbly done, and a pearls of wisdom from a giant is really appreciated, and we learn a lot. I agree that in these days of endovascular treatment, the macrovascular surgery for the aneurysm is slowly declining, especially in my practice. When I started practice, I used to operate all. And nowadays, whenever I give a choice to my patient, whether you will opt for a surgery or whether you will like to go for an endovascular, and believe me, this is my practice, personal practice, and they say, yes, we want to go for an endovascular treatment rather than open surgery. But open surgery cannot be replaced by everything by endovascular. I agree. And it's wonderful to learn again and again from you. And you have a very good techniques and very good pearls of wisdom to give to all of us and learn. Couple of things I would like to know from you. Suppose there is an aneurysm, which is ophthalmic aneurysm, and part of the aneurysm is extradural and part is intradural. What do you do? Do you do a bypass first, or you just try to do? Did you come across such situation?
Yeah, I have. These are very challenging, and I think not only challenging from technical standpoint, but challenging in diagnostic. Like, how can you determine that these are transitional aneurysms that incorporate both subarachnoid space but extradural space? And from a technical standpoint, you have to do a really good, thorough clinoidectomy, and you have to open the distal dural ring, and you have to have good proximal control. Now, if you cannot get good proximal control from the clinoidectomy, sometimes you have to be prepared to open the neck. And sometimes you may not know it's transitional until you see it at the time of surgery. And if you do, you have to be ready to clip it. And sometimes you may have incomplete, clipping. And in which case you don't have good visualization of the portion that's in the clinoidal segment. So we actually encountered a case a couple weeks ago where we clipped this large paraclinoid aneurysm, the intradural portion, but there was a remnant that was still in the extradural portion. The good thing is that these can be treated with flow diverting techniques. So you could probably consider just flow diversion post-op after this, or perhaps even preoperatively, this may be better with flow diverting treatment if that's available to you. So a lot of these paraclinoid aneurysms can be successfully treated using that technique. But diagnostically, it can be hard to distinguish whether it's truly intradural or partially hybrid.
One more thing. Suppose there is a blister aneurysm. Say, mostly we come across in PCOM. That is a blister aneurysm is very commonly seen. Do you straight away clip it, or do you use some muslin gauze or something to hold the clip? Or because I have noticed some chance of slippage of this clips if you clip it directly in a blister aneurysm.
Yes, these blister aneurysms that you referred to are often located on the dorsal surface of the ICA in the supraclinoid segment. And in a ruptured case, these are quite treacherous. I believe that these segments of the ICA is diseased. And so if you try to clip it, it will likely tear and result in a pretty disastrous intraoperative rupture. So I think clip wrapping is a good technique where you take a gauze or an umbilical tape and you sling it across the vessel, and then with a right angle clip, cinch down the clip blade so that the cotton will create a wall around it. I think that's one useful technique. You might want to consider a balloon test occlusion also. I mean, some of my colleagues have advocated bypass for this, as they believe the whole segment of that proximal ICA is diseased and can't be treated. And so carotid sacrifice with revascularization is another technique to be considered. So I think you have to be prepared for all of these options.
One more, in acute hematoma, especially middle cerebral artery aneurysm. There are big clots or medium-sized clots where you said you should go ahead straight away, clipping rather than going for coiling and then decompressing. Did you find that you are in a mess of a clot and perforators are many times difficult to see, especially near the lenticulostriate arteries? Many times difficult to see. And you feel you end up with a, while dissecting, you end up with some perforator injuries, especially in the large hematomas. Is it your experience or you feel it's safe to do that?
Yeah, that's a great question. I think with the large hematomas, I strongly advocate surgery. I think with a large hematoma with mass effect, if you go to the angio suite and you spend a lot of time trying to coil this aneurysm, and then you go to the operating room to decompress the clot, that just makes no sense to me because you're wasting time on mass effect and pressure on the brain. You should go to the OR, take out the clot. So when you take out the clot, you make a small corticectomy and you can aspirate the clot. You don't want to remove all of the clot. You want to remove enough clot to relieve pressure. And then don't try to clip the aneurysm through the clot cavity. I think that's where you can get lost in the anatomy, and that's where you can risk, as you mentioned, the perforator injuries. So what I do is I decompress the clot, but then I come back to the subarachnoid space and open the fissure in the traditional way. Once you find the M1 vessel, just stay close to the vessel. And if you follow the yellow brick road or you follow that vessel in adventitia, it will take you to the bifurcation. It will take you to the neck of the aneurysm, and then identify the perforators and then clip the aneurysm. So I think that's the anatomy will be more distinguishable if you stay in the subarachnoid space as opposed to trying to clip the aneurysm in the clot cavity. That's my suggestion.
Thank you. What about the using adenosine? How often do you use the adenosine and when during dissection?
I've used adenosine in a handful of cases. It's not common. You would only use adenosine if you do not have the ability to achieve proximal and distal control. It's the medication that you would use if all hell breaks loose and you cannot get control of the aneurysm. So as long as you have established, proximal inflow of the aneurysm and the outflow vessel of the aneurysm, you generally don't need to use adenosine. But with that said, I have used it in a small number of cases, mostly AVM rupture, because that's harder to get control of bleeding. But in most aneurysm cases, if you have proximal and distal control, you don't generally need adenosine. I think the location where adenosine can be useful is basilar aneurysms, because sometimes it may be difficult to get proximal control if you don't have enough exposure on the basilar trunk. That's where adenosine can be helpful.
Last question. Sorry, so many questions I'm putting.
Okay.
What about the cavernous artery, intracavernous portion of the aneurysm?
Yeah, cavernous aneurysms, I generally don't treat with open surgery. I refer them to my endovascular colleague. If they are small cavernous aneurysms, we can just merely observe them. But as they become larger or if they become symptomatic, flow diverting stent technology is very useful in treating these.
What is your strategy in unruptured aneurysms?
Unruptured aneurysms, yeah, that's a great question. I think you have to look at the patient as a whole. If it's a patient who has a family history of aneurysms, a positive smoker, any risk factors for increased risk of rupture, if there's any ominous features of the morphology of the aneurysm, I generally recommend treatment for these aneurysms. If it's a small aneurysm without family history, non-smoker, a period of observation is reasonable, but you have to educate the patient of all the relevant risks and so forth, the natural history. So I think some aneurysms can be observed, but some you should treat based on the other factors mentioned.
Wonderful, James. You have given all the arms available in the aneurysm surgery. I don't think anything has been left behind. And I agree with you, more and more training. And most important is the knowing the anatomy and reading the anatomy on the angiogram is must for all of us. And how to remain within the subarachnoid space and dissecting out the arteries, perforators, and preserving these arteries and perforator when you are clipping the aneurysm. Wonderful, very nice techniques. And one more before I end. In a basilar aneurysm, tip aneurysm, how do you decide to go from a left or a right side?
Yeah, that's a great question. Sometimes I use the 3D to distinguish which side the anatomy might be more favorable. I think if you're able to come from your dominant hand side, so if you're right-handed, a right-handed approach can be more favorable. And if you're left-handed, a left-sided approach can be more favorable. That can play a factor. I think in most cases it can be dealer's choice, but if the basilar swings to one side or the other, that can, you pay attention to that. Sometimes you have a tortuous basilar and, it may be pointing to one side. If it does, then coming from that side where it comes closer to you, the anatomy will be closer, making it more favorable.
Very good.
Do you drill PCA for basilar?
I'm sorry.
Do you drill PCA, posterior clinoid?
I'll posterior clinoid on select basis, not routinely. I will remove the anterior clinoid process because that opens up the carotid oculomotor triangle. But the posterior clinoid only on select cases. I don't think it's necessary for every case.
Thank you, James. Thanks. Wonderful.
Yeah,
Looking forward
okay.
to hear you again.
Yeah, thank you, Asha. You're adding to the educational experience. Okay, let's see if we have more questions from the panelists. Okizi, do you have any questions from Nigeria? Or Dr. Berzani from the Netherlands? Are you still connected? Go ahead, Okizi.
Thank you, John. I'm enjoying the lecture. I'm okay. It's always fun to come and listen to this great teacher.
Okay, very good. Okizi's from Nigeria. Are you there, Dr. Bahani? Nicholas, are you there? And,
Yes, I'm here.
oh, there you go, Doctor. Welcome.
Yes, thank you. Nice lecture. Very nice. I enjoyed it. It's just I'm on a place not so convenient to talk a lot, but I enjoy it. Thank you very much, James.
Okay. Thanks for weighing in, Dr. Bahani.
Thank
How
you.
about you, Nicholas? Are you there to say hi? Perhaps not. Okay, James, thank you very much. Pretty extensive teaching lesson, almost 2 hours.
Thank you. Thank you very much.
So, okay, we look forward to part 6 next week, correct?
Thanks,
Okay.
James. Thanks. Looking forward next time.
Okay, thanks
Okay.
everybody for coming. Bye-bye. Thanks.
Bye-bye.